Yeah. Good afternoon, everyone. I'm Sakaguchi, Dean of Faculty of Dental Medicine, Hokkaido University. I'm very glad to host the third joint symposium between Dental Research Institute and School of Dentistry, Seoul National University, and Faculty of Dental Medicine, Hokkaido University. And it is a great pleasure to be here today. We are greatly honored to continue the joint symposium. On behalf of all members of Faculty of Dental Medicine, Hokkaido University, I would like to sincerely appreciate all members of the Dental Research Institute and School of Dentistry, Seoul National University, for their cooperation on joint symposium. The joint symposium between Seoul National University and Hokkaido University is the 23rd in last November. Unfortunately, for 20 years, two dental schools were hopeless about the joint symposium. However, we could hold the first joint symposium in Sapporo, November 2018. And second joint symposium was held in Seoul, November 2019. I'm very glad to take part in the joint symposium. We think the first, the second, and the third three joint symposiums become the foundation of building up a good bridge between two dental schools. And we hope to get the MOU in the near future. COVID-19 is spreading in the world from 2020. Therefore, this joint symposium is held online via Zoom. I hope that the coronavirus goes down and we will be able to communicate face to face again with getting over difficulty of COVID-19. Today, four presenters show the current various topics of dentistry. After presentation, we make time for free discussion. Please discuss actively. From now, my message changed to Japanese. All participants of Seoul National University, please understand it. こんにちは、北海道歯学会の皆さん。ただいまから、北海道歯学会令和2年度秋季学術大会を開催させていただきます。今回は、今お聞きのように、ソウル大学、北海道大学のジョイントシンポジウムを閉催という形でさせていただきました。冬場で秋季というよりは冬季となってしまいますが、学術大会でのですね、学位発表が公聴会に移行して、秋季学術大会の開催に関しては今検討中でございます。どうぞご理解ください。最後までご参加のほどよろしくお願いします。大学院、歯学院の大学院生の皆さん、歯学研究セミナーとなります。もう NMS で周知していますが、課題に関して答えてください。明日の夕方までです。それをもって、出席にしますのでよろしくお願いします。Okay, lastly, through our collaboration, I hope to grow up the good relationship between Dental Research Institute and School of Dentistry, Seoul National University, and Faculty of Dental Medicine, Hokkaido University. Thank you.
Yes.
Yes.
My message finished.
Yes, we have four invited speakers today. Arima Sensei, could you please introduce the Japanese speakers, and I will do the Korean one. Is that okay?
Yeah.
네, 정 교수님 자기 소개를 먼저 하셔야 될 것 같은데. I'm sorry for interrupting that, and our host MC forgot introducing himself. Yeah. So I told him to introduce himself first.
Yes, I am Ji-hoon Chung from Seoul National University, Department of Oral Physiology, and Arima Sensei and I are co-hosting this meeting, and I am the 뭐죠? I'm the associate dean of the planning and coordination. It's a difficult one. Yes. Yeah, that's me. And Arima Sensei, could you please introduce yourself?
Oh, sorry, I'm Taro. As you know, I'm sure all of you know me. I didn't know that I'll be the session chair. I try to do my best. So, okay, let's start with a speaker from Hokkaido University. It's going to be Professor Watanabe. Would you please, yes, thank you. And would you please start your lecture?
Oh, thank you. I will just give an introduction. My name is Yutaka Watanabe. My specialty is gerodontology. I'm very honored to have an opportunity to give this lecture. I would like to special thanks everyone how prepared this symposium and all participations. My presentation about approaches from the dentistry for dementia in Japan. Today's contents. Number 1, environment surrounding dementia in Japan. Number 2, approach from the dentistry for dementia. I will explain separately for Japanese government approach and Japanese Society of Gerodontology approach. Number 1. This graph shows the number of people with dementia changing over time. As you can see, the number of people with dementia is rapidly increasing in Japan. This problem is not only happening in Japan, but also occurring around the world. This graph shows the change in number of people with dementia worldwide. As you can see from this slide, the number of people with dementia will increasing. Sorry, cancel. Sorry. As you can see, the number of people with dementia will increase rapidly like Japan. Now, the number of people with dementia is about 50 million. After 30 years, in 2050, over 123 million people will be living with dementia. The point of this slide is that dementia is a worldwide problem. Number 2, approach from the dentistry for dementia. First, Japanese government approach. This table is a curriculum of dental dementia training for dentists, and this training started from 2016. We created this curriculum with cooperation of the Japanese Ministry of Health, Labor and Welfare. This curriculum consists of 3 parts. First is a basic knowledge of dementia. Second is a social cooperation system and countermeasures for supporting dementia. Third is how to dental treat, conduct dental work on patients with dementia. This part includes video training materials, and the total training program is 3 hours. The curriculum promoted since 2016. One goal of this plan is to ensure that 22,000 dentists will finish this curriculum by 2020. Its mean is 1/5 dentists will finish this curriculum by 2020. This goal has been successfully achieved. Second, Japanese Society of Gerodontology approach. This academic society is one of my main society. There are two main approaches from the Japanese Society of Gerodontology. First is a statement from the position of oral health management in elderly persons with dementia in 2015. Second is a guideline for dental treatment of elderly people with dementia in 2019. By the way, I'm one of these writing and editorial members. First, I would like to address some problems that we face as dentists for elderly people with dementia. In Japan, the number of elderly people with dementia who have many teeth and increasing rapidly, and maintaining a lot of teeth is important for keep their oral health and quality of life. However, this fact leads to higher risk of them suffering from dental disease because there is a higher percentage of people who are over 80 and suffering from dementia. When people suffering from dementia, it is difficult to keep their oral health condition. Please look this picture. You will be able to imagine that will happen in future in this elderly patient with dementia. Because based on the clinical impression in the previous slide, several studies have been carried out. Here is one of the most important findings by our research team. This is a cohort survey of about 500 elderly people. This is who needs nursing care in rural area in Japan. The purpose of this study was to understand the necessity of dental treatment for the elderly with dementia. This data demonstrated the difficulties dentists feel in treating elderly people with dementia in clinical situation. We think that this is an important finding. The need for oral hygiene, dental caries treatment, and periodontal treatment was 2.5, 5.6, and 15.9 times higher for patients with dementia compared to older people without dementia. To deal with such a serious situation, we have published the statement position of oral health management in elderly person with dementia in 2015. This statement was published based the new Orange Plan policy and the current elderly oral situation in Japan. Unfortunately, this statement is only available in Japanese. The new Orange Plan is launched by the Japanese government as a comprehensive strategy to accelerate dementia control. As I mentioned before, high percentage of Japanese elderly people have many of their present teeth remaining. This is excellent. This is excellent in keeping their oral health and quality of life. But this fact leads to a higher risk of elderly people suffering from dental disease because at age of 80 over, there is a higher percentage of people suffering from dementia. When people suffering from dementia, they are unable to keep their oral health condition. Therefore, we created this statement of the position of alert medical staff and the general public about our dentist responsibility for people with dementia. Main content of this statement. Number one, relationship between dementia and oral condition. Number two, points to keep in mind for dental treatment and treatment of patients with dementia and future problem. Number three, Japanese Society of Gerontology's responsibility for people with dementia. Again, we created the statement of the position to alert medical staff and the general public about our dentist responsibility for people with dementia. Next, I'd like to talk about the process of creating the guideline for dental treatment of elderly people with dementia. First, a questionnaire was distributed to find out the problem with treating people with dementia to all members of Japanese Society of Gerontology. And we asked, do you have a clinical question when treating people with dementia? The collected all questionnaires were analyzed by the guideline members. And finally, this led to 593 clinical questions. Because on these clinical questions, the guideline members arranged the data into 7 clinical question categories. Planning dental treatment plan, oral hygiene management, conservative dentistry, oral surgery, prosthodontic treatment, the dysphagia rehabilitation, minimum requirement knowledge of dentist when managing eating difficulties or dysphagia. Based on the 7 clinical question categories, a systematic review was undertaken to create a draft guideline. Finally, the draft consists of 38 essential question categories. Follow-up consensus meeting took place. The recruitment of public comments was undertaken, and preparation for publication began. The guideline for dental treatment of elderly people with dementia was published in June 2019. The guideline was about 180 pages detailing dental treatment of elderly people with dementia. Many dementia are degenerative disease and progressively worse. It is necessary to respond to each stage with predictably, and we have to grasp dental problems according to dementia stage severity. In order to deliver effective and seamless dental treatment for people with dementia, can't see the woods for the trees, and it is important to know the season of the woods. This is part of the PARP, which means the woods being the people who suffer from dementia, and the tree being their oral health condition. Therefore, it is important to know the season which indicates the severity of the dementia. This image leads to dentists being able to provide health care and long-term care service in a timely and appropriate manner as the stage of dementia progress. Shows the conclusion. Measures against dementia are a global problem. measures against dementia have been proposed in many countries. Japan's dementia measures include recommendations on dental treatment. The guideline for dental treatment of elderly people with dementia was published by the Japanese Society of Gerontology in 2019. How is the approach from the dentistry for dementia in Korea? Thank you for your kind attention. Thank you.
Thank you very much. I think we have some time for collecting the discussions or questions, maybe from audience.
Yeah, I have a question.
Yes.
Yeah, but before that, good to see you again, Professor Yokoyama. You were there. Yeah. Yeah, long time no see. Yeah, such please. That's yeah. Professor Watanabe, I have one question. You mentioned that curriculum of dental dementia training in your university, Hokkaido University. Is that a standard program in Japan or in your university's own program?
Oh, sorry.
Yeah.
But so this curriculum to provide the dental college, not dental college. This program, training program provide dental association. Yes.
Okay, understand. Thank you.
Okay. Please go ahead.
음소거.
We can't hear you. Would you please mic on?
Yes. Can you hear that? Hear me? Do you think the dementia patient has a lower condition of oral health? Do you think is there any cause and result relationship? I mean, dementia causes the oral condition, low oral condition, or vice versa?
Thank you. I think main cause is not informed consent. Dementia patients can is so difficult, but concentrate concentration explains. Dementia patient is so sorry. But so I think important is so informed consent. Yes.
Like a long time ago, maybe 10 or more years ago, I saw a Japanese scientist, Japanese dentist. He was saying that oral condition is causing the dementia.
Oh yes.
How do you think of that? How do you reply to that comment?
ディメンシアと口腔内環境とかコンディションの関係についてを質問していると思います。
Yes. I think so. Yes. But so oral condition cause dementia, or but so dementia cause oral condition. I think so. Both root.
Okay, thank you.
Okay. I think it's time to move to the next speaker.
Okay.
Thank you very much, Professor Watanabe.
Thank you.
Thank you very much.
So next speaker is also Assistant Professor Sakaguchi. Okay, yeah.
Yes.
We
Hello,
hey.
Dr. Arimer. Thank you for your. Thank you. Okay, let's start. Good afternoon. I'm Dr. Sakaguchi, prosthodontist. I'm very pleased to have this opportunity to speak to you all today. Oh, okay. My presentation consists of 3 parts. First, how do you or a dentist measure dental occlusion? Second, I will introduce Tscan computerized occlusal analysis system for occlusal examination device. After that, I will introduce evaluation mascatory function and occlusal treatment using Tscan in daily clinical practice. First, how do you or a dentist measure dental occlusion? According to Glossary Prosthodontic Term, edition 9 of Academy Prosthodontic USA, occlusal examination defined as follows. Number 1, examination to determine what kind of dental occlusion subject has. Number 2, static or dynamic occlusal contact in maximum intercuspal position and eccentric position of mandible is measured using articulating paper, wax, silicone occlusal examination material, same-stock occlusion foil strips, and occlusal examination device, etc. Clinically applied occlusal examination method. Number 1, are you using articulating paper? Number 2, are you using same-stock occlusal foil strips? Number 3, are you using silicone occlusal examination material? Or number 4, are you using occlusal examination device, Tscan? Evaluation factor of occlusal examination. Articulating paper and same-stock occlusal foil strips can only determine location. Silicone occlusal examination material cannot identify force. Tscan can determine location and can identify both force and timing, 2 of the most fundamental parameters for measuring occlusion. Maxillary right posterior articulating paper markings with computerized occlusal analysis relative force profile. Photo on the middle shows maxillary right posterior articulating paper markings. Which tooth has a strong occlusal contact? Which tooth has a weak occlusal contact? There are large, broad paper marks present on teeth number 4 and 5. And there are small, narrow dot paper marks present on teeth number 2 and 3. Do you interpret occlusal contact of teeth number 4 and 5 are strong? And those of teeth number 2 and 3 are weak? Right figure shows 2-dimensional occlusal view relative force data in Tscan. Left figure, highlight forces were colored red or pink, and lowest forces were colored blue. Left figure shows 3-dimensional view in Tscan data. Similarly colored column heights describe the relative most and least forceful contact present. Certainly, there are large, broad paper marks present on teeth number 4 and 5, but highest force contact is where there are small marks linear to central fossa of tooth number 3. Note that tooth number 5 has equal total force percentage to tooth number 3, despite visual mark size disparity. Tooth number 4 has a large red mark on its part of cusp, but it measured as very low relative force despite its size. This figure illustrates a best example of how mark size cannot reliably describe occlusal force. This is a picture of my clinical treatment room. I use Tscan to measure, evaluate, and treat dental occlusion. A little bit breakdown. Dr. Mehta gave me Tscan, my boss in USA, director of Craniofacial Pain Center at Tufts University School of Dental Medicine. This 15 years ago, both young. This 5 years ago, IATR meeting held in Boston. This 3 years ago, we had meeting in his room. Both grew old. Let's go back. I introduced Tscan computerized occlusion analysis system or occlusion examination device. So what is Tscan? Tscan is a diagnostic device that can record your patient or subject occlusal force and location over time and continuously. In other words, Tscan is a device that can simultaneously and in real time evaluate location, occlusal force, and timing, which are dynamic changes. The figure on the left shows Tscan setting when using it. Ultra-thin, reusable sensor shaped to fit the dental arch insert into sensor handle, which connected into USB port of laptop. The Tscan has improved since it was introduced by Dr. Manis of Tufts University in Boston in 1978, and is now 5th generation. Here is an example of a dental occlusion movie start. Software vivid 2-dimensional and 3-dimensional tooth contact data highlights each tooth and force level exact on that tooth during occlusion. The figure on the bottom shows graph curve on entire occlusal. After recording the entire occlusion movie, you can store the data and document change in the occlusion over time. Occlusal data can be transferred into other document for patient record or insurance report. These images and report also improve patient communication and education. Parameters are explained here. This figure 2-dimensional occlusal view of relative force data in Tscan. Square color in white and red indicate center of occlusal force. Center of occlusal force is abbreviated as COF. Total trajectory length COF is defined as sum all of effective distance COF from initial tooth contact to central occlusion. COF area is defined as rectangular area of total trajectory COF from initial tooth contact to central occlusion. These two parameters were used to evaluate the stability of occlusion. Shorter total trajectory length COF and smaller COF area was more stable with occlusion. Conversely, longer the total trajectory length of COF and larger COF area was less stable with occlusion. Moreover, COF area indicates magnitude of shifting mandible position anterior posteriorly and laterally from initial tooth contact to central occlusion. Lateral occlusal force distribution is used to evaluate the balance of occlusal force. When entire occlusal force distribution is 100%, if left and right occlusal force distribution are across 50% respectively, it is evaluated that occlusal force balance between left and right side. Lastly, I talk about evaluation musculatory function and muscular treatment using Tscan in daily clinical practice. Before that, I would like to about evaluation musculatory function. Examination for musculatory performance is carried out for objective evaluation of musculatory function. Musculatory performance is an important parameter for objective evaluation of musculatory function. Musculatory performance is measured by using a gummy jelly. Measurement of glucose extraction during chewing of gummy jelly has attracted close attention because simple manipulation needed is control hygiene, possibility of standardization of physical and the other property of gummy jelly as test food, and reports a positive correlation between musculatory performance as measured by this method and that measured by the sieving method. This is currently a well-accepted method in Japan. Test food was cylindrically shaped gummy jelly with a diameter of 14 mm, height of 10 mm, and weight of 2.3 grams. Patients were asked to chew gummy jelly on their habitual chewing side for 20 seconds. After chewing, they were asked to hold 10 mm distilled water in their mouth for a moment. and to spit into cup with a filter. Cup containing gummy jelly and saliva was then filtered, and filtrate was collected. For evaluating mastocytory performance, glucose concentration in filtrate was measured as glucose extraction by means of a glucose testing device. Amount of glucose extraction was used parameter of mastocytory performance. The higher mastocytory performance, higher amount of glucose extraction. So how much does mastocytory function restore before and after removal partial denture treatment? I will introduce 3 cases of unilateral distal extension missing that will provide removal partial denture treatment using Tscan. Case 1, mandibular left side, first and second molars were missing. This case was Eichner index B1 in classification partial edentulous arches. According to two-dimensional occlusal Tscan data before treatment, total trajectory length COF and COF area from initial tooth contact to centric occlusion was short and small respectively, but COF shifted to the right side laterally. Occlusal force distribution was 28.6% on left side and 71.4% on right side. And balance of occlusal force shifted to the right side laterally as well. Amount of glucose extraction was 106 on the left side and 150 on the right side. And this showed mastocytory performance on the left side was low. When a removal partial denture shown in the figure on the middle right side was fabricated and occlusal treatment was performed using Tscan, total trajectory length COF and COF area was short and small respectively, and COF converged to centrality. This shows stability of occlusal contact. Occlusal force distribution was 47.1% on the left side, 52.9% on the right side. And this shows occlusal force balance between left and right side as well. Amount of glucose extraction was 176 on the left side, and it increased by 70 when wearing a removal partial denture. Next, case 2, mandibular left side, second premolar, first and second molar are missing. This case was also Eichner index B1. According to the Tscan data, total trajectory length of COF and COF area was long and large respectively, and this shows occlusal contact was less stable. COF shifted to the right side laterally. Occlusal force distribution was 35.2% on left side and 64.8% on right side. And balance of occlusal force shifted to the right side laterally as well. Amount of glucose extraction was 67 on the left side and 107 on the right side. And this showed mastocytory performance on the left side was low. When a removal partial denture shown in the figure on the middle right side was fabricated and occlusal treatment was performed using Tscan, a total trajectory length COF and COF area were very short and small respectively, and COF converged to centrality. This showed occlusal contact was more stable. Occlusal force distribution was 51.3% on left side and 48.7% on right side. And this showed occlusal force balance between left and right side as well. Amount of glucose extraction was 186 on left side, and it increased by 129 when wearing a removal partial denture on left side. Last, case 3, actually left side second premolar, first and second molars were missing. This is case also Eichner index B1. According to Tscan data, total trajectory COF area was short and small respectively, but COF shifted to the right side laterally. Occlusal force distribution 20.4% on left side and 79.6% on the right side. Balance of occlusal force shifted to the right side lateral as well. Amount of glucose extraction was 45 on the left side and 209 on right side, and this showed musculatory performance on left side was low. When removed partial denture shown in the figure on the top right side was fabricated and occlusive treatment was performed using Tscan, total trajectory length COF and COF area was short and small respectively, and COF converged to centrality. This shows occlusal contact was stable. Occlusal force distribution was 46.3% on the left side and 53.7% on right side. And this showed occlusal force balance between left and right side as well. Amount of occlusal extraction was 185 on left side, and it increased by 140 when wearing removal partial denture on the left side. So, musculatory performance in unilateral free and missing cases in the case of Eichner index B1 is summarized as follows. When removal partial denture were worn by prosthodont treatment and occlusal treatment was performed using Tscan, average amount of glucose extraction was 196 on the left side and 198 on right side during wear of denture. Average amount of glucose extraction was 197 on defective side during wear of denture. Average increased amount of glucose extraction was 100 on defective side during wear of denture. Number of patient sample is 10. So standard value of musculatory performance amount of glucose extraction based on Eichner index, which are in classification partial edentulous arches. I didn't talk about it this time, but I will show you current standard values of musculatory performance based on Eichner index in my data. What is interesting is here that amount of glucose extraction is almost the same on the left and right side in each group of Eichner index. This may have suggested the following possibility. When removal partial denture worn by prosthodont treatment and occlusal treatment was performed using Tscan, impaired musculatory performance restored in each classification B1 to C3, and musculatory performance is exhibited equivalently on both left and right side. Number of patient sample in each group of Eichner index is 10. In other words, in treatment of denture prosthesis for patients with muscular disorder due to missing teeth, when dynamic occlusal evaluation is carried out and occlusal treatment performed so that occlusal stability and balance can be obtained, there are following possibilities. Impaired musculatory function on defective side may have restored to the same level as the healthy side, and musculatory function is exhibited equivalently on both left and right sides. This is a message from President Japan Prosthodontic Society. In this message, he has said follows. It's essential to improve form and function abnormalities in stomatognostic system by prosthodontic treatment, and to quantitatively measure improved stomatognostic function by objective evaluation. It's identity prosthodontics that can learn this improvement and assessment. And at the same time, this identity is the core and the specialty of prosthodontics. Today, I talk about just a few importance of quantitative measurement and objective evaluation for functional improvement by prosthodontic treatment. I'm sorry I couldn't talk about academic research this time. I greatly appreciate for your kind attention. Thank you so much. That's it, all set.
Thank you very much. Okay, now it's time for the discussion. If you have any questions from the audience.
Yes, thank you very much for your great presentation. I have 2 questions. One is that I think the sensor for Tscan is like a temporary one, one-time use one. How much is that in Japan, and is it covered by insurance?
You mean the cost for device or
no, sensor
for the treatment?
Yeah, sensor. Yeah.
Cost for the treatment.
I have no idea, but I guess probably 10 seat is $100, maybe. Sorry.
For one paper, you mean that?
Maybe one paper is Japanese 1000 yen. You know.
1000 yen.
Maybe.
Okay. Okay. 1,000 in Korea, right?
A little bit expensive.
10,000 won.
Yeah, and I have a second question. That your study that show the relation between the musculatory performance and the area measured by Tscan is, I think this is a really wonderful study. And if your study proves that there is a close relation between the glucose level, I mean the musculatory performance, and the area measured by Tscan, so from now on, we don't need to measure the musculatory performance by other method. Only Tscan, that means that the area of the teeth is a reliable measure for the patient muscular performance, is right? What is your opinion on that?
Thank you, Professor, your question. Good question. But very difficult for me for your question. But today, what I would like to talk about today, in treatment of dental prosthesis for patients with a muscular disorder due to missing teeth, one dynamic occlusal evaluation is carried out, and occlusal treatment is performed using objective evaluation device, so that occlusal stability and balance can be obtained. Today's my suggestions. So I would like to Tscan not only occlusal force evaluation and examination device, but also for occlusal treatment device as a treatment method for occlusal adjustment. So I think there are various methods to evaluate the muscular performance. I think it's important to measure before and after treatment based on the objective evaluation method, and objectively evaluate the degree of recovery after treatment. Therefore, even if the evaluation method is different, it is important to objectively measure the degree of recovery within the individual and evaluate it objectively. So now, the glucose extraction standard value for dental wearers is over 100 milligram, and for healthy dentition is over 100 milligram per deciliter in Japan. So I want more patient sampling. So I continue the sampling. This is answer your question. I'm sorry, but
okay, thank you very much. Yeah.
Thank you, Professor.
Yeah. Anyway, yeah, you did a very wonderful job.
Thank you so much.
Okay, other questions? Okay, I think it's a time to shift to Korean team. Okay, thank you very much.
So much.
Yes, before we go to the next station, could we take a photo time?
Oh.
Yeah, everyone with camera, please turn on your camera, and we'll take a picture.
写真撮るので、
Hi, it's
カメラオンにしてください、皆さん。
most important thing.
group photo.
Now it's 109 persons participating.
Wow, amazing, amazing.
Yes.
Mhm.
Yeah. The next speaker is Ryan Jinyoung Kim. He's the future of our school. He's a specialist in conservative dentistry, and he's now working in the dental education department.
Did you take a photo
Yeah, I did.
already?
I will send it to you.
You need to say 1, 2, 3 next time. Okay.
하나, 둘, 셋.
Professor Ryan,
Yes, hello.
we are looking at your, yeah.
Okay. All right. Hello, everyone.
Okay.
I am Ryan Jinyoung Kim, assistant professor here at Seoul National University School of Dentistry. It is my great pleasure to meet all of you, unfortunately online, and give this presentation. I'm going to talk about how our university has been affected by COVID-19. My presentation is not research focused, not research oriented at all. So just sharing my, our experience. So please sit back. I'm going to spend 20 minutes on this topic. Okay, the COVID-19 pandemic represents the worst public health crisis of the 21st century. Just briefly going through the history, in China 2019, in December, dozens of cases of pneumonia from unknown cause was reported. And the same virus was found in Japan and Korea in January 2020. So we just had 1 year anniversary. Yes. On February 11th, WHO officially named the disease caused by SARS-CoV-2 virus as COVID-19. That stands for Coronavirus Disease 2019. And as the number of COVID-19 cases exponentially increased, globally, WHO declared as pandemic on March 11th. It is still causing so much frustrations in every aspect of our life. Dental education was not an exception. Because the virus is transmitted by breathing or touching contaminated surface, and then if you touch, your eye, nose, mouth, we had to adhere to preventive measures, including social distancing, personal protective equipment, and hand hygiene. As we all have experienced, social distancing is the most important strategy. That's why many dental schools have been locked down to minimize the spread of infection. According to this study, the data was obtained from dental educators globally in April, May last year. So at that time, all lectures were processed in online, except in Taiwan. As you all know, Taiwan only has very minimum, extremely low number of cases, confirmed cases. It's under 900 in total. That's why they are taking face-to-face classes and simulation lab courses, as well as clinical training courses remain proceeded only in Taiwan. This is an overview of our curriculum. After completion of pre-dental requirements, 3 to 4 years pre-dental requirements, our 4-year main dental curriculum can be broadly divided into 2 main categories like this. For the first and second year dental students, they spend at dental school, most of their time at dental school, and gain theoretical knowledges and work on mannequins for preclinical training. And as they advance into third year, most of their time is spent at our dental hospital for patient-based clinical training. Although the structure was not fully affected by the COVID-19, we had to work and cooperate with each individual and students to follow the government policies and recommendations so that we can make safe decisions for patients, students, and faculty. In March last year, in response to the government policy, our university has distributed COVID-19 guidelines to all members, letting them know what to expect in case of these symptoms or if there is any suspected contact with COVID patients. We are currently at a declining stage of the third wave, but we are restricted according to the level 2.5 instruction, which include banning on gathering of more than 5 people. So we can only gather, only up to 4 people at this stage until the end of this month. I'm sure you have seen some of these photos to cover their nose, mouth during early phase of outbreak. There was, huge mask shortage. It was extremely difficult to buy a mask at that time. Back in April, May, I remember waiting long queue, more than 1 hour, but all you could buy was five masks maximum, if you're lucky, per person. Anyway, coming back to our university, all our facilities have multiple entrance and exit doors. However, only one-way entrance and exit was allowed for better screening and close monitoring. These are some of the systems we have placed on every entrance. Everyone entering the facility should check the temperature by standing in front of automated temperature scanner, which also detects any person without mask. And the person has to register QR codes to help fast track whenever necessary, followed by verbal and written screening, and then of course, alcohol hand sanitizing. One of the mandatory programs had to be canceled. Our 4th year senior students, they get opportunity to spend their 2 weeks at an international dental school and designated hospital. But the program is designed to let them broaden their knowledge and think outside the box of Seoul National University. But last year, due to travel restriction and mandatory quarantine measures for 14 days if you travel overseas, extension program was not provided. And this year, it's likely to be canceled again. Just like any other countries, traditional face-to-face offline classes have been switched to online mode to keep on the learning progress. There are different systems available in the internet like Zoom meeting, Google Classroom, Google Meet, Skype, yeah, you name it, so on for online learning. So it is not difficult to keep the social distance for this kind of study. Among all these commonly used learning platforms, our school has been using Zoom, video conferencing platform for real-time interactive class. In the beginning of the crisis, we announced online class for the first 2 weeks because we didn't know it's going to take this long, two weeks, and then extended to full first semester. And because COVID-19 was not going to disappear, it was inevitable to extend online class indefinitely until further notice. Let's take a look at Seoul National University's student perception on online education. This survey was conducted from roughly about 2,500 students, not only from dental school. It was collected in April, May last year. So please remember that the numbers would be different if surveyed today. Overall satisfaction, 4.05 out of 5. And dental students, in fact, actually rated really high, above 4.5, showing that they were pretty satisfied how online is operated. And most students use their notebook followed by desktop, tablet, and mobile for connection. And they were connected at home mostly, or other places like cafe, followed by in campus. The most commonly listed challenges were increased assignments and study material given by tutors, because it's done, online, and network instability. Actually, although we thought that our internet connection wouldn't have any problem, but we experienced network instability when a large group was connected simultaneously and sharing large video clips during the early phase of outbreak. But this doesn't seem to be an issue since Zoom has updated along the way. And obviously, two-way communications between professors and students and between students, peers, was shown to be not as effective as traditional. And students preferred, regarding most preferred online class, students preferred videotape materials, Zoom, and recorded PPT in descending order over just giving them lecture notes or assignments. As you all know, the technology has its benefits, but it's also not without faulty, right? Yeah, there were concerns regarding privacy and security during real-time online classes. So we issued a guideline first, like this, don't take or circulate pictures and videos, don't display private information, update Zoom regularly for security, and don't share Zoom password like that. Yes, moving on to preclinical education. For preclinical learning activities, online simulation with dental training mannequin is not possible, right? Yeah, although different clinical simulators have been on the market developed and showing satisfying results like haptic technology. In the MOOC Simodont, we have 3 of those, but the thing is the number of training equipment is very, very limited, and they are not portable, and they do not cover all areas of dentistry. And the most important, very, very expensive. Or there are some other tools like virtual reality training tools, VR, but still current facilities are not good enough. Yes, this is a photo of preclinical lab, and yeah, all this kind of simulation lab procedure and final work needs to be checked step by step by the tutor and by the tutors. So in other words, simulation lab courses need close contact between tutor and student. This is preclinical simulation lab with mannequins on a traditional routine day. And this is how we try to operate by leaving a space between two students to provide distancing whenever possible by dividing groups. In addition, everyone was required to wear face shield, goggles, disposable apron. Disposable apron is not easy to see on this photo because it's transparent, and mask all times. Patient-based clinical training is another aspect, is the most difficult part of dental education to deal with, especially in a pandemic situation like today. Direct patient management in real clinical sessions remains essential in developing skills and competencies of a general dental practitioner. So no e-learning strategies can replace experience with patients yet. our student clinic was actually temporarily closed in March and April and reopened in May 2020. The pandemic disrupted the clinical experiences for students who had not completed sufficient clinical requirements. During aerosol producing procedures in real patients, everybody, regardless students, faculty, staff, everyone is a possible source of infection because we are all in close contact. So we should follow universal precaution in infection control, which is that we should regard everyone as if they are infected. So we had to implement all the possible measures to prevent spread of infection while continuing treating patients. Everyone in the treating clinic is required to wear face shield, goggles, gloves, disposable gowns, mask, not just dental mask, but more protective N95 equivalent KF94 mask at all times, and use high volume suctions at all times and rub them whenever it's possible. Okay, this is the student clinic where students see patients daily on the left. And this type of care on the left photo, top left photo is not accepted. As you can see, no masks, no goggles, no protective gowns is not accepted anymore. Students and instructors used to wear just basic protective gowns, like one on the right, just basic protective gown, but face shield, goggles was not mandatory at that time. But since the COVID-19 crisis, students should wear face shield, goggle, either disposable plastic apron on the left or disposable gown on the right at all times, and surgical cap if possible like this. And of course, routine hand hygiene and disinfecting the clinic before and after seeing each patient cannot be emphasized enough. Okay, so let me sum up. The COVID-19 pandemic significantly impacted dental education. Luckily, we are currently providing both online lecture and face-to-face preclinical and clinical training. For online classes, because COVID-19 has been ongoing far too long, both professors and students are now very used to online classes, and it seems quite effective. But I still believe there is a room for improvement in terms of content of study material and quality of device, such as microphone and webcam. And definitely, we should adhere to online, keeping social distancing whenever possible during this crisis. But preclinical and clinical training cannot be substituted by online training. So we should implement every possible preventive measures in ensuring students' right to learn while protecting their health and safety. And regarding reduced clinical activities, we should reconsider adopting interactive technologies, and curriculum should be innovated to suit different situations. The thing is, our students are all experiencing increased level of stress. So it will be beneficial to provide counseling support for students, even like chatting, as you just move around. If you bump into someone, like simple chatting will help. And if there is going to any change or concern, it is our responsibility to actively communicate plans with students and involve them in the decision-making process. These are the key elements for reducing students' anxiety. Okay, to face the future challenge, we have to be cautious but not panic, being flexible and willing to face the changes because we never know what is coming next. Yeah, that's it from me. And later, if we have time, it would be great to hear from professors from Hokkaido University how you are dealing with COVID-19 so that we can learn from your experience. Thank you very much.
Yes, anybody has a comment or questions about the topic?
Okay, I have some questions from Japan. Yes, Sakawaka. Okay. Thank you very much. A good presentation. Your presentation is very interesting for me. And in Japan, almost learning using online, but it is very difficult to assessment for students. For example, periodontology, endodontics, and so on. It's our university use writing the testing to use many number of the room, keep the social distancing, but it's a very not bad, very not good conditions. You are Seoul National University. How do you assess the students?
Because our COVID-19 situation is not as bad as any other countries, we are implementing the routine assessment at this time, like close monitoring, step-by-step assessment. So there is not much difference if we compare with pre-COVID-19 and post-pandemic. Yeah, there is no difference. We are just keeping our fingers crossed so that we don't get many COVID-19 positive patients. Otherwise, we might need to close down. We might need to lock down the clinic. But luckily, at this stage, there is no difference in terms of assessment. So we just strictly adhering to preventive measures, what we can do, every possible measures. Yeah, just like that. But there is no difference in terms of assessment. So that's why we would like to learn from you, because you never know just around the corner what's going to come around the corner. We have to learn from you how we can deal with assessment in case there is increased number of positive patients.
Thank you, but I don't know. I want to teach, but I don't know the procedure. It's very difficult.
Okay.
Thank you.
So you start the face-to-face lecture around the spring of 2020, right? And then we started the face-to-face treatment or clinical training from May 2020, right?
Yes.
So based on how did you decide it's okay to restart the clinical?
Okay, it's because COVID-19 situation is, unprecedented. It's first situation to anybody experiencing. So there was no clear rule, but it was we had to adhere to government policy, because at that time, in the early phase of COVID-19 in March, April, there was slight increase of positive patients in Korea. So government advised us to do and our the government policy is just like that. So but as the time goes on, the number.
Sorry, I'll answer this question. it was too hard to answer, I think.
And because the number of patients declined a little bit as time goes on in April, we had to reopen the clinic. Otherwise, how would students learn clinical skills, and how would students learn, competency on patients without reopening? But luckily, we were able to continue face-to-face training. Yes, thanks to everyone wearing mask and hand sanitizing. Yeah.
Thank you.
Okay.
Yes, is there any other questions? Yeah, thank you very much. Our last speaker is Professor Sinet Chung. She's a specialist in conservative dentistry and now working in the biomaterial department. You there?
Hello, everyone. Nice to meet you. I'm trying to put my PPT on the show. Okay. I think you guys are looking at my script. Is it right?
No, we are looking in your face.
Oh, really? Okay. Sorry. Okay, is this the one?
Yes, it's starting.
Okay.
It is there.
And I should do the this one, right? Is now, can you see my script?
Yeah,
It should be hidden.
No.
No, not anymore.
Yeah.
It should be hidden. Okay. May I start? Thank you. Everybody. Good afternoon, and thank you very much. Well, first of all, I would like to appreciate everybody from Hokkaido and also from our school for this online joint symposium. And I'm really happy, and actually I'm a little bit nervous to present my my work, my studies at 23rd HU and SNU joint symposium. Okay. And if you have any questions, you don't need to hesitate. You could bother anytime you want. As Professor Chung introduced, my name is Chung Shin-hye, and I'm an associate professor at the Department of Dental Biomaterial Science. Since my background is from clinical, since I have clinical backgrounds, my studies are originally based on the clinical questions. So my topic today is about elevation of marginal and evaluation of marginal and internal adaptation of CAD/CAM fabricated inlays and crowns. It's actually, I use CEREC system. My presentation will deal with evaluating method used in two different studies: marginal adaptation and leakage of inlays with different gingival margin was studied through microscopic and microcity evaluation. In this study, interfacial gap formation in the lithium disilicate inlays with and without margin modification was compared. And the other one, we will deal with marginal and internal adaptation of single crowns with different heights. The first one is interfacial gap formation of inlays. The objective was to compare the interfacial gap formation with and without margin elevation. First, I prepared MOD inlay cavity to the 12 extracted mandibular molars with margin elevation means RMGI cement was used to elevate the deep cavity to make the final size of the preparation to 4 millimeters in buccal width, 3 millimeters in occlusion depth, and 4 millimeters in axial depth of the proximal box. All the gingival margins of the proximal boxes were located beneath the segmental enamel junction to mimic the clinical situation of the worst situation that we can see in the real clinics. Specimens were embedded in an epoxy resin, exposing only crown portions for the next step. And RMGI, because I saw that one of the participants in this symposium was from GC, and I would like to, I'm glad that I could show this picture of GC product. Each cavity was scanned with Serec Omnicam, and CAD design was obtained from the Serec software. Since inlays have more complex geometry than full coverage crowns, the segmental space was set by 150 micrometers to provide interfacial clearance, which is sufficient for internal adjustment. 120 spacer setting was normally used because it's the default spacer, but I used 150 in this case. A lithium disilicate block from Vericom, which is made in Korea, it was used. After about 13 minutes of milling, the samples were crystallized using multimed cube, which is also from the Dentistry. Right after the crystallization, the lithium disilicate surface was etched with hydrofluoric acid and treated with saline. Inlays were cemented with Reliax U200, the resin cement, and 24 hours later, after storing in water, the marginal adaptation and marginal leakage was evaluated before the aging process. 1 million cycles of aging, artificial aging, was made with chewing simulator. As you see on this photo, the load was applied at the central fossa with a 1 millimeter round-ended tip. The loaded weight was 94 Newton. For the marginal discontinuity under low magnification, we evaluate the surface with stereoscopy microscope and also with scanning electron microscope. None of the specimen with elevation, which means when we use RMGI to elevate the margin, did not show marginal discontinuity in both before and after the aging process. While 50% of without elevation, which is a deep margin with no treatment, showed discontinuity before aging, and it increased to 60% after the aging. Even there was no significant gap formation before, artificial aging itself seemed to be contributing in gap formation. This is the picture of SEM with the margin. We focused on the special defects that were initially produced and gradually progressed not only at the adhesive interface, but also within the cemental layer. For the effective microcity evaluation, a silver nitrate infiltration technique was used. After a silver nitrate infiltration for 6 hours in dark at a room temperature, microcity was taken. Since we had to deal with other noises and also we had to know where the leakage was coming from, the percentage of the silver nitrate and the infiltration time had to be controlled. After several minor adjustments, the volumetric evaluation of marginal leakage was obtained at each point. These are the reconstructed images of dye penetration model. The penetration was extended in both groups after cycling. The smaller, the green color, the gaps colored with green stands for margin elevation, and red color showing marginal the spaces marginal leakage for the volume of the marginal leakage without margin elevation. All of the samples had marginal leakage, but from the microscopic evaluation, we could not determine whether it was penetrating or not. There are some circled images demonstrating dye penetrated interfaces between inlay and dentinal floor. These images show the whole specimen and the dye penetrations with surrounding substrates filtered out. We filtered out all the noises, and without elevation, almost no penetration was seen at the interface between the inlay and dentinal floor, which was minimally increased after cycling. In elevation group, the presence of silver nitrate was not detectable at the interface between the inlay and RMGI base. RMGI showed a slight increased radio opacity, but not leakage. It doesn't mean that the RMGI had absorbed some of the silver nitrate, but it didn't mean that marginal leakage was occurred. From the determination of volumes of interfacial dye penetration, proximal boxes with margin elevation revealed significantly less interfacial gap volume compared to those without margin elevation. After cycling, the volumetric gap increased in both groups, and the increment was less in the with elevation group. The penetration was extended in both groups after cycling, after the aging. For the internal and marginal adaptation of single crowns with different heights of abutments, marginal adaptation have been known varying depending on abutment specifications. So we made a premolar model with 4 millimeters to 10 millimeters height, and we made Serac lithium disilicate single crown as previously described. Single inlays, a lithium disilicate block from Haas in this time was used, which is also made in Korea. It's the purple block on the left side. Haas is a company which launched the first zirconia pediatric zirconia shell. So they say 3 types of lithium disilicate based products are available now in Japan. So these results are from Haas lithium disilicate blocks. We made 17 references, and distance between in each crown were measured, briefly comparing internal gap formation of only the shortest and the longest abutment. Marginal and axial corner side gaps increased as the height of abutment increased, but not total. So some of the gaps were not significantly different, but marginal gaps and axial gaps and the gaps of the corner seem to be very significant. So the conclusions are: deep margin elevation with RMGI decreased the interfacial gap formation, and marginal elevation decreased initial gap and also the gap increment after the aging process. The interfacial integration mainly occurred in the deep areas of proximal cavities, while surface remained very, very untouched through the aging process. Marginal and internal gap formation was increased as the height of abutment increased. And the three-dimensional evaluation rather than microscopic evaluation should be considered to increase accuracy in measuring marginal and internal discrepancies in CAD/CAM fabricated restorations. Thank you very much, and arigatou gozaimasu. And if you have any questions, please do not hesitate. Thank you very much.
Yes, if anybody has a comment or question, please come forward.
Okay, I'm just interested in simulator.
Chewing simulator.
Yeah. How does it look like?
It looks like a ball.
Yeah.
We can make it in a ball shape, or we can make it in a cylinder shape, and it touched the surface of the restoration. And we have we can use up to 6 kilograms of the load on the surface here. Can I make a? Okay, we can load upper side on the upper side here, and we can make it up to 6 kilograms.
Mm-hmm.
And here we put the sample, and here we put the sample. So if you are making samples, two sample, you have to make it upper and under sample into tooth. But I used only under. I used the cylinder, the spherical tip to load on the tooth inlay surface. So, and these white what should I say, white cavity. This white tube is for the water. So we could determine the temperature, but I used 5 Celsius and 55 Celsius. The temperatures to make it to mimic the artificial aging, like thermal cycling.
Mm-hmm. So what does 6 kilo means? We normally do 6 kilograms for eatings.
Yeah, it's much more than 6. I know, I know, but I don't know. I'm not sure about this. I used 5 kilograms, but this device are designed to use up to 6 kilograms. Yeah. The reason I choose 5 kilograms, although the amount of load we get while we are chewing will be over 60 kilograms, as I know, but when we are loading on specific point, because I use only central fossa to load, so I thought maybe I thought we could divide it into, when we divide it into whole occlusive surface, there might be less than 60 kilograms. So I think that's the reason they made this device to load up to only 6 kilograms.
Okay. Thank you.
Thank you very much.
Chair.
Can I hear you?
Yes, I can hear you. Thank you very much.
Yeah, thank you. Thank you.
Yeah.
I'm waiting for the chair.
Oh, yeah.
Yeah, this is
See?
this is the last speaker of today, and Dean Professor Hobam Kwon, could I request you closing remarks?
Okay, I think that this is the final time for today's conference. Professors, students, and all of the participants, including Dean Yawaka, thank you very much. It's been a truly inspiring day for me. First of all, I would like to express my appreciation to the speakers. Dementia, using digital device measuring occlusion, coping with COVID-19, and digital restoration technology all are important, interesting topics. You have done an outstanding preparation and shared your valuable knowledge and insights and experience with us. Thank you, Professor Taro Arima and Jiun Jung, for a wonderful job. I think we are a really talented person in MC. I believe you made this symposium better. Also, thanks to Dean Yawaka and all of the professors who prepared this symposium, you showed us a persistent support for this conference. This is the third joint symposium between Hokkaido University and Seoul National University. I think this is the outstanding example of academic exchange. But because of COVID-19 pandemic, we did not visit each other this time. This conference was too short for us, and we did not even have dinner together. So we have a plan to go to the Japanese restaurant today for the conference dinner, as if we visit Sapporo today. Fortunately, there is a restaurant named Sapporo in Seoul, so we are going to go there and enjoy conference dinner by ourselves. Next time, I hope we visit Sapporo and Seoul and have enough time for catching up each other. On behalf of Seoul National University, I would like to thank you again, all of the professors and students and Dean Yawaka and Hokkaido University. We look forward to seeing you again. Thank you very much.
Thank you. Thank you. See you in fall this year, maybe, or winter. Okay.
Or summer, or next spring, please. Yeah, or whenever. Yeah.
Okay. Have a nice day.
Okay, thank you.
Okay, bye. Yeah, see you next time. Yeah.
See you.
Thank you very much.
You.
Bye-bye.
수고하셨습니다.
Bye.